The first thing I wanted to address is why Professor Braswell and I wanted to talk about COVID-19 and disability. And I think there are many reasons, but I wanted to highlight the most important ones, at least in my mind, for you. The first is more than 1 in 4 Americans have some form of disability, right? You might see different figures in different places, but that's a figure that's based on the most recent census data. So we're talking about a huge part of the American population and, over 85 million people. The second reason I think it's important to think about disability when we think of COVID-19 is amongst the people who are most often cited as being particularly vulnerable to COVID-19, and that would be people with lung disease or asthma, serious heart conditions, diabetes, kidney or liver issues, or who are immunocompromised, are largely people with disabilities. Those conditions would typically fall under the Americans with Disabilities Act definition of disability, which is a physical or mental impairment that substantially limits a major life activity. I think people with disabilities, people with certain disabilities may also be less able to take protective measures that we're all being advised to take. It can be harder to practice physical distancing if you need assistance in your daily life or if you live in a group setting. Certain disabilities might also make it more difficult to engage in hand washing, put on a mask, those kind of activities. So you might have seen articles like this. I think COVID-19 presents a host of disability equity issues, but we want to focus today on decisions to allocate scarce healthcare resources, also sometimes called triage policies. Ventilators are one example, perhaps the most prominent example, but not the only example. Hospital beds and the time and attention of healthcare workers are also scarce healthcare resources, among others. So in the absence of a federal policy on how scarce resources should be allocated, states and institutions are creating their own allocation policies. And in some cases, these are created through an open, transparent process with community participation, but in other cases, not. And some healthcare institutions do not have a formalized policy, which is also very concerning. Because as the sub-headline suggests, some of these policies appear to discriminate against people with disabilities.
Building on what Elizabeth talked about with regard to the disability bioethics, so that means bioethicists involved with the disability rights movement, critique of quality of life, and how there's kind of been a consensus around survivability being a better criteria for determining who gets scarce medical resources. So with that, slide please. So here's the critique of quality of life. The idea is that quality of life is a subjective measure. It's based on an individual clinician's assessment of how much the patient or class of patients, disabled people in this case, might enjoy their life in the context of a particular condition. So it's a judgment about someone else's enjoyment of a particular situation. What's the problem? Such judgments are often wrong. They're wrong in general, but they're wrong in particular with regard to non-disabled people's judgments of the quality of life of disabled people. Disabled people, in fact, have been shown via numerous studies to rate their quality of life as substantially higher than non-disabled people assume it to be, and indeed often higher than non-disabled people themselves. This is referred to as the disability paradox, if you're familiar with that. So against the assumption that a disability necessarily impairs one's quality of life. So this has been a critique you've probably seen a lot if you're on Twitter, as I am, or following the news. It's been made by Ari Neiman in the pages of the New York Times, by Alice Wong on Vox, and by Tony Coelho, longtime disability rights advocate in the New York Daily News. And I think it's a pretty broadly shared critique among disability rights advocates. Next slide, please. So quality of life, the basic idea again, just to rehash, though seemingly neutral, it seems like a neutral thing. In fact, it smuggles in discriminatory attitudes towards disabled people. When this is incorporated into triage policy, these attitudes are violent. They result in death. They result in disabled people not getting medical care that they could benefit from, and in the current situation, that can often result in death. So that's like the general shape of the disability studies critique of triage criteria. Now, this is used primarily with regard to quality of life, but this general idea that a seemingly neutral term is used to smuggle in discriminatory attitudes can also be used to other categories, even those that are seemingly more neutral and objective. That's a broad consensus, I think. Quality of life is bad. Survivability is, better, okay? It's better. But there still is a debate amongst people who I think are involved in disability bioethics, and that's regarding a criteria that would be accompanying survivability. So survivability would be one criteria, and it could be paired with another one. And that would be level of resource commitment criteria. So what this means is how many resources are going to be needed to help save this person's life. That's the level of resource commitment. How many resources are we gonna have to commit? Now, some people require more resources than others, and some people might require a lot more resources than others. We don't consider that in general when it comes to life-saving decisions, or at least that's what we say. But in the pandemic, there's a debate about whether we should consider it given the limitations of existing medical resources. So that's the debate. Next slide, please. What does Joe say? Joe says no. It may take more resources to get the job done. It may take more resources to save someone's life, but those resources are not wasted. They save someone's life.